Good afternoon, everyone. The topic for discussion is hemophilia in children. I'll be dealing this topic in 3 sessions. Today, we will discuss on the pathogenesis, the clinical manifestations, and the management in general. So back to a bit basics. What is hemostasis? It is the process of blood clotting in the areas of injury. So 5 major components are involved. As you all know, the vessel wall, the platelets, the clotting factors, the anticoagulants, and the fibrinolytic system. And it has been divided into 3 phases. That is, first of all, the change occurring is a vascular phase, that is constriction of the vessel wall, followed by the platelet phase, that is aggregation of the platelets. So up to this is the primary hemostasis, that is till the formation of a platelet plug is the primary hemostasis, and the coagulation phase soon follows, that is with the activation of the clotting factors. So this is an overview of all the functions that is occurring inside the body during hemostasis. That is, the intact vascular endothelium forms as a barrier against hemorrhage, and it also prevents clotting by providing a smooth surface for the free flow of blood. Whenever there is an injury, that is, it can be due to an hypoxic injury, inflammation, infection, whatever it is, there will be vasoconstriction occurring and the platelets are activated, as I have mentioned earlier. And the first factor that comes into action is the von Willebrand's factor. And this is followed by the coagulation cascade. The clotting factors comes into action in order to form a blood clot. Over time, the fibrinolytic factors comes into action to lyse the clot, and antithrombotic factors are also there, like protein C, protein S, antithrombin, TFPI, etc. And with all these, the platelet plug formation and lysis of the clot occurs. That is the primary and secondary hemostasis. And the primary hemostasis, the major component, as I have already mentioned, that is the von Willebrand's factor. You can see the small factors. This factor form a glue over which the platelets are getting adhered. The tethering of the platelets to the site occurs, and with the help of glycoprotein 1b receptors, more and more platelets are getting attached and aggregation occurs. And as we all know, the platelet release reaction occurs with the ADP, thromboxane, serotonin, and other proteins on the granules. So a platelet clot is formed along with the fibrinogen with the 2b3A receptors. And why I'm giving stress on this von Willebrand's factor is that we are using Immunite. Immunite is the combination of factor 8 plus von Willebrand's factor. So in previously untreated patients, it is of benefit that it increases the half-life of the factor 8. It is seen bound with the factor 8, and in previously untreated patients, it also reduces the inhibitor formation by joining at the C1 domain. So along with fibrinogen, the second stage is also over. So hemostasis is an overall initiation, amplification, and propagation of all these mechanisms like a thrombin burst generation and the fibrin clot formation. You are all familiar with this intrinsic pathway, extrinsic pathway, common pathway, and all the coagulation factors involved. That is starting from the prekallikrein, factor 12, and the final step of this is the activation of factor 10 to 10A, 12, 12A, 11, 11A, 9, 9A, 8A, and factor 10 to 10A. The importance of extrinsic pathway is whenever there is the endothelial matrix is exposed due to injury, the tissue factor is released. It joins with factor 7A, and the importance is the factor 7A can directly activate the factor 10. Then this common pathway occurs, prothrombin to thrombin, fibrinogen forms fibrin clots, and finally the factor 13. This helps to formation of a stable clot. With the defect of factor 13, a friable clot only is getting formed. And among these factors which have been isolated, more frequently found defects are the factor 8, factor 9, then factor 5, 13, factor 7, etc. So there is a critical balance between procoagulants and anticoagulants within the body, and actually anticoagulants predominate to maintain the flowing nature of the blood. So we'll come to hemophilia proper. That is, it is an X-linked disorder. Deficiency of factor 8 is called hemophilia A, and factor 9 is hemophilia B. And it is an X-linked disorder That is, the defect is in the long arm of the X chromosome. You can see the yellow arrow here. That is the long arm of this position is the XQ27 in case of hemophilia B, that is factor 9 deficiency, and XQ28 is for hemophilia A. And sometimes, so there will be always a family history, but it can occur due to spontaneous mutations also of the factor 8 gene. So this is the pedigree chart showing the inheritance from a male with congenital hemophilia. That is, in a usual scenario where father is the patient, what happens is all the daughters will be carriers, but none of the sons are affected. Whereas if the mother is a carrier, that is the one of the X chromosome is defective, 50% of the sons can get affected and 50% of the daughters will also be the carriers. So that is the importance of X-linked inheritance. And depending upon the factor level, as you all know, many of the factors in our body are of 50 to 150 range level, normal level. And when it is so, it is 5 to 40%, it is a mild hemophilia, 1 to 5% is moderate hemophilia, and less than 1% only forms severe hemophilia. And the same thing, that is according to the clotting factor level. That is, when it is severe means less than 1 international unit per deciliter. That means less than 0.01 international units per ml. So there will be chance of spontaneous hemorrhages, major bleeds, etc. Whereas in mild hemophilia, that is 5 to 40 international units per deciliter, or 5 to 40% of the normal, means severe bleeding occurs only after trauma or surgery. But in case of moderate hemophiliacs, that is 1 to 5%, sometimes they may be of increased bleeding phenotype. That can also occur in moderate hemophilia. We'll come to the incidence in different sites of bleeding in hemophiliacs. As you all know, the hemarthrosis is the hallmark of hemophilia, with 70 to 80% of occurring, and muscle and soft tissue bleeding 10 to 20%, and CNS bleeds, that is major bleeds, abdominal bleeds, CNS bleeds, iliopsoas bleeds, such bleeds occur less than 5%, but once it occurs, it is very severe and difficult to manage. And among the joint bleeds, certain joints are more prone to hemophiliac hemarthrosis. So ankles and knee, you can see 42% in ankle and 20% in the knees, and other joints are less percentage affected, that is shoulder 4%. You know why is it so? These are the weight bearing agents, of course, more prone to trauma, but the thing is that these joints are hinge joints where the synovial trapping occurs more, and this synovium is rich in vascularity, so they get traumatized early. Whereas in ball and socket joints, the incidence of hemorrhage is less. This is a child with hemarthrosis of the elbow. It's a hallmark of the disease. Then you can see one of the common occurrence, that is following a fall or trauma, the child can have muscle bleeds along with joint bleeds, or joint bleeds start first, or a spontaneous bleeding that associated with muscle bleeds can also occur. This is a typical deep ecchymosis in a child, and you can see a difficult venous access, child is having a calcified hematoma. All these are common presentations. And this is also a thrombophlebitis followed by infection of the dorsum of the hand. This is a hematoma. It can be a trauma due to a tooth, sharp tooth. And this is also following a fall. Orbital hematomas are also not that rare. It can be seen in children. And this is when you elicit the history, one of the most important point is immunization history of hematoma following immunization. This is a case of hematoma. Hematoma can occur in normal children also, but if the children is having a bleeding or coagulation disorder, always there is a chance of hematoma formation. So that should be inquired into. And this is a case of following a traumatic delivery. The baby can have a subgaleal hemorrhage or a cephalhematoma. All these are important points to be elicited in the history also. You can see the pathetic situation with an extensive thrombophlebitis over the hand, elbow, and the arm. This was associated with an hemarthrosis of the elbow and intravenous access on the same site, and circumcision. That is again one of the dangerous bleeds. The child may go in for shock with circumcision if there is no family history and done under local anesthesia, and prolonged bleeding and shock can occur. So you should be always careful. You have to get the coagulation profile done in all cases of surgical cases. Whenever a child with hemophilia presents with excessive tiredness, vomiting, headache, altered behavior, where you will suspect an intracranial bleed, but with lethargy or seizure episode or visual problems, you should rule out an intracranial bleed. The management and clinical manifestations we'll discuss later. So we'll come to whenever you suspect a coagulation disorder or a bleeding disorder, how will you approach? As in any other case, we should start from the history. That is age of onset and type of bleed. If there is a family history, it is easy. But you have to elicit in a fresh case, you have to elicit all these spontaneous or post-traumatic previous or family history, bleeding from the umbilical stump, cephalohematoma, as I mentioned earlier, hematoma at the vaccination site, circumcision bleeding, symptoms correlate with the degree of injury. That's also very important in traumatic bleeds, dental procedures, following tonsillectomy, prolonged bleeding can occur both in bleeding disorders and in coagulation disorder. It will be early in case of a bleeding disorder, whereas in coagulation disorder, there can be 2 to 3 days gap also. And of course, menorrhagia in bleeding disorders. So again, when you examine, the examination should focus upon the type of bleeds. Usually in platelet and bleeding disorders, platelet function or bleeding disorders, there will be purpuras and petechiae, that is less than 3 millimeter bleed and 3 to 5 millimeter bleeds. But there is no hard and fast rules. But in hemophiliacs or coagulation disorders, usually it is ecchymosis, deep ecchymosis, hematomas, and other joint manifestations. When there is mucocutaneous bleeding, more frequently seen condition is von Willebrand disease. And clotting factor deficiencies, there can be family history more than that of the bleeding disorders, and deep and extensive ecchymosis, deep hematomas, and joint bleeds occurs. So how to suspect a bleed? After eliciting the history, in a coagulation disorder, in a nutshell, that is a male child with or without family history of bleeding at birth, ecchymotic patches, joint bleeds in creeping, weight bearing, etc., and mucosal and deep bleeds, you have to suspect a coagulation disorder. So how will you approach? How will you test to rule out a coagulation disorder? As you all know, we'll be doing a peripheral smear, a blood count, a platelet count, and a coagulation profile. And from the coagulation profile, we'll be getting a clue. That is prothrombin type and activated thromboplastin type. Prolonged APTT always reflects an intrinsic factor deficiency, whereas if both PT and APTT are prolonged, should always think about conditions like vitamin K dependent bleeding, liver disorders, and factors of the common pathway, that is factor 5, factor 10, fibrinogen, etc. Normal value of APTT is 26 to 40 seconds. PT is 11 to 13. In children, it can be up to 16 maximum. That is a maximum value of PT, and INR being 0.8 to 1.1. Only PT is prolonged. The most common condition where PT only is prolonged is extrinsic pathway, that is factor 7 deficiency. And rare thing, inhibitors like lupus anticoagulant, antiphospholipid antibodies, heparin and heparin-like substances, and high molecular weight kininogens. That is rare occurrence, but still these conditions, or a pseudo-hemophilia, that can also occur. And after getting a prolonged APTT, what you should do? That is, this mixing studies form the basis of the factor assay, inhibitor assay, etc. Even a bedside estimation is possible, provided you are mixing the patient's blood with a normal person's blood, 50-50 mix. And you should do an APTT first, followed by mixing. And if we repeat the APTT, that should be corrected. If it is getting corrected, that means the patient is deficient in the factor 8 or factor 9. And if it is not getting corrected, that means the patient will be having an inhibitor. These things will come to later. Okay. So we have diagnosed, we have suspected a coagulation disorder, elicited the history. Now we have to start managing the case. So I'll be dealing with the management of a joint bleed today, and other bleeds we'll discuss in the next session. So as you all know, the PRICE, that is the acronym used, that is the protection of the area. It's a common sense. Any area where bleeding occurs, we have to keep the area under rest, protect the area, rest, and ice. Application of ice is very important. It can reduce the pain, and also the child can have rest with compression, crepe bandages, and application of ice. We have to follow the guidelines. That is, never apply ice directly over the joint or the site. You have to cover the ice cubes with a cloth and apply. It should be applied for 15 to 20 minutes, 2 to 3 times per day. And you have to compress the area and elevate the area. In case of children, we can use splints, and the child can get rested on mother's lap with a pillow to elevate the other part of the body. So now the mnemonic by WFH recommended is RICE, that is rest, ice, compress, and elevation. And they modified it as POLICE, that is the principle behind is optimal loading. That is, we should not continue rest for long. The child has to have small starting short movements. That is, if it is kept under flexion, that is a rest position, mild flexion, you should start slowly extending the joint whenever the pain is getting subsided. So gradual movements can be started. So that is optimal loading. Rest for long is not recommended. Then application of ice, compression, elevation, that is the POLICE. That is the acronym used now. And now we'll come to specific management. Specific management, as you all know, is the factor replacement. So now we have FFP, cryoprecipitate, those used in previous times, and these agents are available. The blood components are available for managing factor 13 deficiency and so many other indications. But now for management of clotting factor deficiencies, factor 8 and factor 9, we have clotting factors available. Both plasma derived and recombinant factors are available, and non-factor concentrates like emicizumab, concizumab, fitusiran, etc. are also available. So FFP contains almost all the factors. That is, we can use it in factor 9 deficiency, but of course for factor 8 deficiency, we have to use factor cryoprecipitate because it contains factor 5, factor 8, and factor 13. And World Federation of Hemophilia recommends plasma-derived or recombinant concentrate in preference to cryoprecipitate or FFP, but no preference for recombinant products over plasma. There is nothing to choose in between the two, but the issues of concern are, that is, the technology is developing like anything. So purity, viral inactivation, and heat treatment, solvent detergent treatment, and nanofiltrations are more with this recombinant products. So we can choose depending upon the availability. Now we'll come to the clotting factor concentrates. That is available with us is the plasma-derived factor. Factor 8 concentrates for hemophilia A is 250 to 3000 unit vials. Each international unit per kg will raise 2 units per deciliter of factor 8. Half-life of factor 8 is 8 to 12 hours. And it should be given as low IV infusion, 3 ml per minute in adults and 100 units per minute in young children. And subsequent dosages ideally based on the half-life and the recovery in an individual patient for a particular product. So many tests are available to check the factor level, the trough level, etc., and the pharmacokinetics. In case of hemophilia B, we should use factor 9 concentrates, and each unit per kg of factor 9 will raise the 1 units per deciliter. In case of factor 8, it is 2. Here it is 1, and the half-life is double, that is 18 to 24 hours. And prothrombin complex concentrate like FEBA also contains these factors. These are the factor 8, that is hemophil M, and factor 9 is immunine. The available strength is 600. Available strength is 600. And the recombinant products, standard half-life, that is SHL short form, and extended half-life are available in different and more different strength, smaller volume of infusion, increased half-life with EHL products, and higher trough levels. These are safe and efficacious and more prolonged stability after reconstitution. So the World Federation of Hemophilia has recommended all the factors required in different bleeds. There are 2 types of practice pattern can be used. That is, one is when there is a resource constraint, we can use a lower dose pattern. And when there are adequate resources, we can use higher dose patterns. But for major bleeds, better to use the high dose patterns, at least for the first 1 to 3 days. These different bleeds, how will you manage? We'll discuss later. But joint bleed, if you take 10 to 20, peak factor level 10 to 20 units per deciliter, duration first 1 to 2 days. And for 2 to 3 days, you should give for 10 to 20. You can see the peak factor level in high dose pattern comes around 40 to 60. Like that, if you take an intracranial bleed, 50 to 80 during the initial 1 to 3 days, whereas high dose pattern is 80 to 100. These things we'll discuss in detail in the next session. Okay, these are the other bleeds, GI bleeds, renal, laceration. What should you do in surgery? That we'll discuss. And we can all download the WFH guidelines, 2020 guidelines. You can download. Everything is given, factor 9 and factor 8, both together. Okay, so we'll come to a joint bleed. How will you diagnose a joint bleed? When will you suspect a joint bleed? If you see a case, a fresh case, that is a rapid loss of range of motion associated with pain, unusual, the child will feel. If the child is a chronic hemophiliac, he can feel the sensation and unusual sensation within the joint, and pain will be there at rest, palpable swelling will be there, pain at the ends of range, and there will be warmth of the skin because of the bleeding inside. Onset as a tingling sensation or tightness within the joint, that is called aura. How will you calculate the dose for bleeding? Actually, if you suspect a bleed and if the child is a non-hemophiliac, you can treat first. Even without, the dictum is treat first, image second. So you don't have to wait for an ultrasound getting done. If it is a new case and in doubt, you can send the child for an ultrasound. The number of factors is factor used is body weight in kilograms into desired factor level. If you plan to give it in 40 to 60%, that is into 0.5, because 1 unit is 2. That we have already mentioned. So it should be repeated 12 hourly. The calculated dosage should be given 12 hourly till hemostasis. For factor 9 deficiency, we don't have to multiply it with 0.5. That is body weight into desired factor 9 increase percentage of normal to be repeated every 24 hours till hemostasis. So that can be given OD, and factor 8 should be given 12 hourly. So we'll see if a 30 kg child has come with a hemarthrosis of knee. So how much factor? Desired peak level 10 to 20, both we can opt. If there are adequate resources, we can factors available, we can use 40 to 60, but we can try, better to try with 10 to 20 with the 10 to 20 units. That is 30 into, if you take 40 into 0.5. So we have to use 600 units. That means the vial strength available is 250. So 2 vials 12 hourly for 1 to 2 days to avoid wastage, and reduce the dose to 10 to 20 units per day 12 hourly and stop. If you are choosing 10 to 20, that can be given for first 2 days or first 24 hours, then you can switch over to the reduced dosage. So maximum 3 days is enough. If in some children, you may require long depending upon the response. And flexion will be most comfortable position in joint bleeds. And secondary muscle spasm will be there. Joint appears frozen. And the goal of treatment is to stop the bleeding at the earliest. Ideally, at aura, we have to start. And the dictum I have already mentioned is treat first and image second, and administer appropriate dose of factor. Factor replacement needed within 72 hours. That means excellent response. And if it is a good response, that means significant pain relief and or improvement in signs of bleeding within approximately 8 hours of single factor infusion, but requiring more than one infusion within 72 hours for complete resolution. And moderate relief means moderate pain relief only will be there, or improvement of signs of bleeding approximately 8 hours after initial infusion and requiring more than one infusion within 72 hours, but without complete resolution. And we have to avoid bearing weight after administering the factors. Immobilize with splint. Apply ice for 15 to 20 minutes every 4 to 6 hours. No direct contact of eyes with the affected part. If bleeding does not stop, second infusion, half the initial amount. And further evaluation, if fever, features of septic arthritis, fractures, etc., that is very important that we have to monitor the child closely. And gradual extension following the resolution of symptoms. Will you do an arthrocentesis? If there is even severe swelling which is not responding, will you do an arthrocentesis? That is a question. WFH is not recommending this arthrocentesis to any child. But if the bleeding is tense, severe pain, and no improvement after conservative treatment, and pain that cannot be alleviated with the neurovascular compromise, that is very important. We have to check the pulse rate and neurovascular compromise if you suspect, and if there is any evidence of septic arthritis, it can be done using a large bore needle under factor cover at least 48 to 72 hours, 30 to 50 international units per deciliter, and immobilize with mild decompression, compression and weight bearing to be avoided for 24 to 48 hours. So usually, as far as possible, this should be avoided. And what happens if there is a collection of blood for long? The boggy synovium, grossly distended joint, no little pain, the muscle atrophy can occur, and the enlarged bone ends later damage that we'll come to later. And what is target joint? 3 or more bleeds, spontaneous bleed within a consecutive 6 months period occurring. That is 3 episodes of bleeding within a joint is called a target joint within a period of 6 months. Then how will you manage the pain? Strategies of pain management. There will be severe pain. So first and foremost, the important thing is we have to administer factors. And most of the children will be having less pain if you treat properly. You can give paracetamol during the first 24 hours. There will be pain. We can use paracetamol 15 milligram per kg per dose, 4 to 6 hourly. And selective cyclooxygenase COX-2 inhibitors, that is celecoxib and etoricoxib, is also recommended. 50 and 100 milligram tablets are available. The dosage is also recommended, but better not to use NSAIDs. But though it is being recommended for severe pain, better not to use because so many bleeding manifestations have been reported with the mefenamic acid, nimesulide, etc. And paracetamol with codeine, it is also recommended not below 12 years. But if there is severe pain, 1 or 2 doses can be given. That is being recommended. Other pharmacological options, of course, we can use tranexamic acid. 500 milligram tablets are available. 500 milligram per 5 ml IV preparations also available, and syrup formulations. For older children, 500 milligram TID, 25 milligram per kg, half the dose for younger children. And you can make it a paste and apply over the affected area, and mouth rinse can also be done for oral bleeds. And of course, it is contraindicated in hematuria and with prothrombin complex concentrate, that is FEBA. Should not give tranexamic acid along with FEBA. Regular treatment is of no value. We have to advise the patient not to use it regularly. During the bleed only, it is effective. And ESCA, if the bleeding is not getting control with all these measures, you can use epsilon aminocaproic acid. This is also available. Then for mild hemophiliacs, desmopressin may be helpful. And for moderate also, but of course not in severe cases, intravenous, subcutaneous and intranasal preparations are available. You can use it 0.3 microgram per kg. That is desmopressin. And now we'll come to the vaccination, very important. And many are scared to vaccinate their children if they are hemophiliacs. But all the vaccines, including COVID vaccine, can be given to hemophiliacs also, because there is no problem with immunity in case of hemophilia affected children. So they should receive all the vaccines, and they should receive the vaccine preferably by subcutaneous route, and almost all the vaccines can be given. Previously, there was some problem with tetanus vaccine, but now this is also being given as a subcutaneous route, and TT vaccine can be given, and there has been no evidence of vaccination resulting in inhibited development. COVID vaccine, they recommend is administer 1 dose of factor before vaccination, and use the smallest gauge needle available. You should inform that you are a hemophiliac, your child is a hemophiliac. So apply pressure for at least 10 minutes following the injection. So factor given during the day followed by vaccination and apply pressure for at least 10 minutes. And an ice pack can be applied at the site 5 minutes before. This can be done in all vaccinations. And if there is any redness or swelling, you have to report that also. And post-injection, the healthcare personnel should inspect the site 2 to 4 hours later, because there is chance of delayed hematoma, discomfort in the arm can be there, report if any swelling, persistent pain, or if any allergic reactions, as in any case of adverse reactions following vaccination. And children with immunosuppression, WFH recommends all routine kill vaccines, influenza, hepatitis B, pneumococcal, and no live vaccine as in any other case. Okay, in general, there are certain do's and don'ts because we can avoid trauma by certain advices. They can play certain games, but they should not do all these. See, the football, that is contact sports, should be avoided. Car race, of course, and you should advise the young adults, the late adolescents, better not to use the bike. So many cases of bike accidents, and it can result in severe trauma, management complications. So the parents should be very careful to avoid contact sport. Of course, they can walk, they can swim, they can do cycling, the basketball event, TT, all these games are possible. So these should be encouraged. And this is very important, both for the patient and at the treating facility. They should carry the treatment records, and it should be maintained at the treatment facility also. Whenever a patient comes, a non-hemophiliac, we should know the details of the patient, and the patient should carry his details also. And encourage physical activity by all means, because all joint bleeds should be followed by graded exercises for normal neuromuscular development. Once muscle atrophy develops, it is very difficult. The joint damage can occur. So they should maintain their body weight. They should not be overweight. So a balanced diet should be recommended with increase adequate amount of fruits and vegetables in order to have vitamin D, vitamin C, and they should have the self-esteem. So overweight should not be encouraged, because the sedentary habits are very common with hemophiliacs. The bone density may be decreased. The promote weight-bearing activities and care of the veins. Their veins are their lifelines. So we have to take care, special care of their veins, especially during prophylaxis. And healthy diet habit and dental hygiene is very important, because each tooth acts as one patient. The bleeding can occur if there are unhealthy gums and teeth. Each time they bleeds, so many factors should be used and so many complications can arise. So the dental hygiene is very important. We should always give stress on dental hygiene, and stress on immunization has already been discussed, and psychological support to the child and the family is very important. And the comprehensive care, that is, all the specialties shown here are very important as far as a patient is managed, especially chronic arthritis or following a bleed. An orthopedician, a psychologist, physiatrist, physiotherapist, hematologist, all should be involved as a comprehensive multidisciplinary care for chronic hemophiliacs. So thank you.